the Gloria Neidorf Memorial Lecture on Bipolar Disorder, and it's being presented by Dr. John Brooks, who's the Associate Professor in Psychiatry at the Semel Institute for Neuroscience and Human Behavior. Thank you so much.
What about now? There we go. Dr. Altschuler unfortunately couldn't be here because of a last-minute death in the family, so she asked me to deliver the lecture for her. So, not having given her lecture before, we'll see how it goes. But this is the Gloria Neidorf Memorial Lecture, and what I'm going to be talking about today is the treatment of bipolar depression. And these are Dr. Altschuler's disclosures. Mine would only overlap with Merck. So, one of the things, as people may be familiar with bipolar disorders, is characterized by a lot of ups.
Can you speak louder?
Louder? Okay, move this up a bit. Is that better? Okay. What I was saying in bipolar disorders, people may be familiar, is characterized by many ups and downs. And the particular cycles that people go through are very individual, and the length between cycles, the amount of the highs and the depth of the lows, all varies according to the individual. As you also may be aware, bipolar disorder is usually referred to as manic depression and is characterized by periods of mania where people have elevated mood, rapid thoughts. They can be very grandiose, engage in a lot of impulsive and at times self-destructive behaviors because of the impulsivity. And they also greatly increase their goal-directed behaviors in terms of starting many projects which they aren't able to stay organized long enough to finish. For mania, interspersed with periods of feeling okay, or what we refer to as euthymia, there are also periods of depression, and that's what we're really going to focus more on today is the depressive aspects of bipolar disorder, because those are the area, that's the area that's really the importance which is not fully appreciated. In periods of depression, as you may think, people go through periods of the day where they feel depressed most of the time. They have decreased energy, increased or decreased appetite, insomnia, and usually a decreased amount of movement and activity, decreased involvement in their normal activities. Now, in bipolar disorder in particular, even though major depression is fairly common amongst the population, amongst mental illnesses, bipolar disorder is less common. It is prevalent in about this is 1%, other people usually say about 3 to 4% of the population. And even though that sounds like a reasonably small number at 3%, bipolar disorder, relative to major depression, accounts for much more, a disproportionate amount of cost related to illness. For example, even though major depression may be about 3 to 4 times more common than bipolar disorder accounts for about half as much in terms of health care costs, and even more than that in terms of time lost from work when compared to major depression. So even though it's not as common, the cost of society and the impact on the individual are actually disproportionately greater than in major depression, for example. Bipolar disorder usually has its onset in the early 20s, and there are even earlier onset cases where patients experience onset before age of 20, about a fourth of the time. One area that my research focuses on is bipolar disorder in older adults, which I'm not going to go over here, but just as an aside, since I'm here and I'm giving the talk and I can talk about it. What you actually see, if you look at older people, and by older we take a very liberal definition of older, starting at 55. And what you see is if you look at people 55 and older who have bipolar disorder, the age of their illness onset is often in their early 40s. So there's actually a distribution in terms of age at onset of the illness from, although it's most common in the 20s, you can also see it later on in the 40s as well. In bipolar disorder, the incidence of suicide is relatively high at about 15%, and that's most common in what we refer to as mixed episodes, which you can think of as sort of a combination between manic and depressive episodes. So patients aren't feeling good, they're depressed, but they're fairly agitated and have increased activity. In almost all cases of bipolar disorder, there's some recurrence of the illness after the initial episode. So it's not just, as you might know, a one-time thing. Interestingly, you may have also heard of seasonal affective disorder, which is described as a variation in mood according to the seasons and is thought to be related to perhaps length of day. Some people have argued that that could be a variant of bipolar disorder. And if you look at bipolar disorder itself on this slide, what you see is that incidence of depression increased in the spring months and the fall and decreases over the summer, whereas mania begins its upswing in March and it's kind of on a down curve by September and October. I used to work in a VA hospital at Stanford for about 12 years before coming to UCLA. And on the inpatient ward there, I can tell you March was a very busy month because I think amongst the population we treated, this was a much steeper curve. So March could get very, very busy. Now, oftentimes in bipolar disorder, which to some extent is correct, people do relatively well when they're not at the extremes of a mood episode. However, there are several studies that have shown that depression is a major factor in bipolar disorder, even more so than the manic episodes. Manic episodes tend to get more attention just because of the content of the elevated mood and increased activity and the things that people do. But in terms of the impact on the person with bipolar disorder, actually depression is relatively important. In these two studies of around 600 people, bipolar type 1 patients, those are patients who have mania and depression, in contrast to type 2, which I'll talk about in the next slide, spend about 30 to 35% of the time in a depressed episode, and about 10 to 12% in a manic episode. So people spend about three times as much time depressed as they do manic. So you can see then in terms of treatment, even though many treatments focus on mania just because of the explosiveness of it and everything, depression is rather important as well. One thing that Dr. Altshuler and I have been working on is in terms of bipolar type 2. And bipolar type 2 differs from type 1 in that instead of episodes of mania, they're episodes of hypomania. So instead of being quite as disorganized or perhaps having any symptoms of psychosis, it's just an elevated mood, which usually is pretty enjoyable and can actually be a period of increased productivity unless things get just a little too far to the hypomanic side, in which case they fall apart. But amongst type 2 bipolar patients, this slide actually should say number of weeks hypomanic, since bipolar type 2 by definition can't be manic. They spend an even greater percentage of their weeks, according to this most commonly cited study, depressed. They spend about 50% of their time depressed, and about 2 to 7% of the time in an elevated mood episode such as hypomania. So you can see even though a lot of focus is usually drawn on manic or perhaps hypomanic episodes, bipolar depression is really rather important in terms of the impact in someone's life. There are the different options, which is what we'll focus on today, the different options of treating bipolar depression. There are a number of approved treatments, and they're not specific to bipolar type 1 or type 2 depression, but bipolar depression in general. And they range from antidepressants to lithium, anticonvulsants such as the anti-epileptic drugs, which have become a relatively effective Lamotrigine and valproate. I'll go over some of this in a little bit more detail in terms of how well I won't go through each one in detail, but how well some of them address treating depression versus others. Some medications which were previously referred to as antipsychotics have since been found to have a pretty significant effect on bipolar depression, namely Quetiapine or Seroquel, and then a combination of Olanzapine, which is Zyprexa, plus fluoxetine. These medications have also been found to have significant mood stabilizing properties in terms of treating mania. So even though they were initially approved by the FDA for treatment of schizophrenia, they've actually found a much wider use as additional trials have been done. Other medications that have been effective include pramipexole, which is a bit newer, modafinil, which is usually used for daytime sleepiness, Pendolol, which is a beta blocker, and various stimulants. Some people have some debate over using stimulants in bipolar disorder in terms of precipitating a mood elevation, but the data on that aren't completely clear. Other therapies that have been used in terms of treatment of depression are light therapy, which usually requires the light to be within a specific wavelength, sleep deprivation, and then herbal remedies such as St. John's wort. Omega-3 fatty acids, specifically with different balances of the acids within them, can be effective for some people. Other newer treatments that you may have heard of include repetitive transmagnetic stimulation, transcranial magnetic stimulation, where magnetic probes are placed outside the skull and then you focus magnetic waves for specific areas of the brain. Vagal nerve stimulation and electroshock therapy, or ECT. Lithium's been used in bipolar disorder for quite a while, and it's usually been used it's associated with treating elevated mood. However, over the years, there's been quite a bit of data that suggests that lithium is effective in treating depression, bipolar disorder. And not only is it effective in treating depression, which I'll go over in a bit, but it also has been shown to reduce the risk of suicide in particular. This is collective data across several studies, but with and without lithium, the number of suicidal acts per 100 patient years is about 2. And patients on lithium, that decreases to about a quarter. So it's about a 7 to 8-fold decrease, which is what's reflected in the risk reduction ratio. If you're on lithium, you have about a 7-fold decreased risk of engaging in a suicidal act with it over time. However, even with this 0.26 is 2 times greater than the risk of suicide in the general population, which is about 0.1. So I mentioned Lamotrigine is a very good treatment for depression, bipolar depression, and it's interestingly, the approval for it isn't actually as a treatment for bipolar depression, but as maintenance treatment for bipolar depression, which makes life a little bit complicated in terms of when you actually start Lamotrigine, because if it's good for maintenance but not acute treatment, it doesn't make a lot of sense. As we'll see, however, in a couple of slides, there are data that suggests that Lamotrigine is, in fact, a pretty good treatment for bipolar depression. Without going through these in details, basically what I'm going to go over the next slide is kind of a combination of a couple of studies that looked at Lamotrigine as a maintenance mood stabilizer for patients who were either recently depressed or manic with bipolar type 1. And this included about 1,300 patients, and these were in a placebo-controlled trial. And what you see, lithium was included not to compare the effectiveness of Lamotrigine and lithium, which would be interesting, but the study wasn't designed for that. It was basically to ensure that there was some effect. But what you see is this is the percentage of patients who remain intervention-free after starting either Lamotrigine at 100 to 400 milligrams a day, or lithium, or placebo. So as you can see, as you go out here, the orange Lamotrigine line stays much higher than the other two. And statistically, that's separated from the placebo condition, meaning that Lamotrigine kept patients intervention-free after a depressive episode in a manner that was superior to placebo. After 18 months, even though it looks like it's higher than lithium here, after 18 months, as you can see, the ending percentages, 60% of the people on Lamotrigine were intervention-free versus about 40% who were depressed. So in this slide, we're looking at, let's skip that slide. So as I mentioned before, there are 2 FDA-approved agents for the treatment of bipolar depression. One is Seroquel or Quetiapine, and the other is Symbyax, which is a combination of Olanzapine, which is Zyprexa, plus fluoxetine, which is formerly Prozac before it went off patent. And these two, as single-agent treatment for bipolar depression, are actually fairly effective. If you look in this study, I don't remember exactly how many people were in it. Oh, there we go, it's 700. If we look at this, the red line, which is the olanzapine-fluoxetine combination, versus green, which is olanzapine alone, versus the yellow squares, which are just placebo, What we're looking at here is this graph is, of course, flipped around. So this is improvement. So as your depression rating scale score goes down, the better you are. So you want to be as low on this graph as you can, because that means that your depression is decreased. What you see is even as early as about a week and a half or 2 weeks, the Olanzapine fluoxetine combination begins to separate from placebo. And as you go through time, the separation gets even greater and then maintains through weeks 6 to 8. And even though olanzapine has been found to have some antidepressant effects itself, because as I mentioned, some of the newer antipsychotic agents have been found to be good at mood stabilization and treatment of depression, you can see that by combining it with fluoxetine, you get an extra benefit here over just Zyprexa alone. Now for Quetiapine, or Seroquel, I should back up. It's like, if we know that olanzapine and fluoxetine are pretty good at treating bipolar depression, then you may wonder, well, isn't that good enough? But one of the issues with Zyprexa is that it's not uncommon that people gain a fair amount of weight with it due to an increased appetite, which leads to what you've probably heard of as metabolic syndrome, as an increased incidence of diabetes. And so even though it's effective, oftentimes telling people that they need to eat less food and exercise more is not an effective way to counteract the increased weight gain associated with Zyprexa. So if you look at Quetiapine, Quetiapine has, while it's certainly not side effect free, it has a little bit more favorable weight gain profile relative to Zyprexa. And so in the study that I'll talk about just briefly, patients went through a 1 to 4 week washout of medications, so they became medication free. And then they were assigned to either placebo for 8 weeks, 300 milligrams of Quetiapine, or 600 milligrams. Normally, before I get to the results, normally when Quetiapine is used in the treatment of schizophrenia, typically you see doses on the order of 600 to 800 milligrams a day, or in some patients with more chronic conditions that could even go higher, up to 1,400 or 2,000 milligrams a day. However, as you'll see with bipolar depression, the efficacy is not necessarily associated with a greater dose. And what was found in this study is that both 600 and 300 milligrams of Quetiapine gave rise to equal efficacy in the treatment of depression. And this was not a treatment in terms of just seeing a response, but actually treatment to remission. And they defined remission as a score of less than 12 on the Montgomery-Åsberg Depression Rating Scale. A score of less than 12 is usually considered within the range of kind of normal good mood, less than 12. So you can see here, both of them relative to the placebo rate of about 26% or so, you can see that Quetiapine 600, 300 milligrams led to equal efficacy. Now with Quetiapine, the major side effect is drowsiness. And for most people, 600 milligrams is associated with more drowsiness than 300. And so it makes sense if you can get away in terms of with a lower dose, and you can also decrease the side effect profile. If we looked in both, in this